I haven't done that study per se. As an economist, I think about the profit margin as a signal sent by the market. And we want, in my opinion, from my perspective, we want to send the message, if we value something, we will give you profit for it. And if we don't value it, we won't give you profit for it. From my perspective, this seems like a rational way to communicate, to use the profit as a signal. However, there are other behaviors that might be incented given the incentives that are set with our limitations currently. So from my perspective, the concern is not necessarily the large profits. The concern is the alignment between the profits and the value that we perceive is occurring from these products.
Which, again, I think is a fair answer. And just to give a little bit of data, this past year in 2015, the net profit margins for doctors, for physicians like Dr. Pan or Dr. Rambula among our colleagues, was negative 1.5% net profit. Sorry, Dr. Pan.
I've always thought he should get more.
For health plans, that net profit number is about 3%. For hospitals, that net profit number was 4%. Last year, for our top drug manufacturers, that profit was 20%. Now, I want to just make another point, which is you have a concluding thought around really the lack of transparency and how we're paying for this. Over the last 20 years, we've had a conversation as a country to squeeze out price inflation when it comes to doctors and hospitals and health plans. I'll just mention, for doctors, there is tremendous transparency required under Medicare. For hospitals, there's tremendous transparency required under OSHPD and the ACA. Health plans have to reveal their medical loss ratios, but there's just not only is there not transparency, we just don't know answers. We have no idea. In fact, as policymakers, we really can't get at what other agencies contract with and negotiate. So do you have any thoughts about whether price transparency could help?
I've been doing a bit of thinking about that one. For starters, we're not unusual in that we don't have a lot of transparency going on. It's very hard to find a place in the world where there is a drug company that is explaining how they arrived at their price and saying that is the actual price. So I've always thought there might be something inherent in the way the system is structured to be built in such a way that it's not transparent. That said, again, from an academic perspective, there may be some advantages, and I know I'm not supposed to be saying this now, but there may be some advantages to lacking transparency. In some situations, for some payers that may afford certain discounts. But it makes it very difficult to be efficient when some of that information is missing. So it's a little bit of a choice between two decisions that are about things that could be quite difficult. The transparency would help. However, when I look around the world, I don't see any of it. So I sometimes wonder, well, what's the best we can do without the transparency? And sometimes I wonder, it's not necessarily the transparency, but it's the thinking behind the transparency and the idea that one must justify how we're arriving at what we're arriving at.
And I think just to conclude, and I appreciate the answers, this is one of the very few industries where it's both a monopoly and we don't have transparency around costs. When there are other monopolies in the economic marketplace, typically policymakers are able to gather costs so that we can provide a fair rate of return. Right? That's true with utilities and other monopolies. That's not the case here. And again, I appreciate your answers. We will keep mulling over them.
Mr. Thurman and then Dr. Pan.
Thank you, Mr. Chair. Thank you for the presentation. I wanted to go back to the opening remarks made by Dr. Hoke. Sorry. You said that there were different life expectancies in the U.S. as compared to other countries, even though in the U.S. we end up spending more for drugs. And I was interested in your data, and if your data drilled down specifically into life expectancy when it comes to cancer treatment, and if we were seeing any trends in different life expectancy for cancer patients versus in the U.S. versus cancer patients in other countries.
This is a Still got to turn it on. Sorry. This is a fantastic question. And
I only deal with the fantastic questions. I'm obviously interested in cancer treatment as someone like many who's had family members touched by this, and intrigued by the notion that you stated from your data, we're paying more in this country and getting less. From the standpoint of those who are being treated from cancer, are we seeing that same trend? Is there a difference? So I appreciate whatever you can share.
Thank you. So 2 thoughts on this. First, this is not for cancer, so it would be wrong to say that what I've said here holds for that particular disease. The second is, although I don't have the answer to your question, I have something that might be closely related, and that is that in the United States, we have access to medications sooner than many other countries in the world. And that might be related to the premium that we're paying. Whether or not those translate into substantially larger or better outcomes is a different story, but perhaps medical tourism to this country could answer that question. So from my perspective, I see our market receiving innovation sooner, which, knock on wood, would lead to potentially better outcomes, but I don't have the data to show it to you. And in addition to which, I should mention there are, of course, other things that go into how long you live and how well you do besides pharmaceuticals and besides healthcare.
Perhaps a future study will stand by.
I'll look for funding. Thank you.
We'll help you find something. Thank you.
Dr. Pan and then Dr. Hernandez.
Well, thank you, and it's good to see some old colleagues from the center here at UC Davis. A couple questions. So I know that most of the talk was actually focused on certainly on the expense side, and certainly that is the main public concern, but I think there's also some concerns about shortages. And so when we look at the overall economic picture for medications, you have some. You talked about specialty drugs, particularly perhaps new drugs, perhaps another. You have, we can talk about spending going up and new drugs and, how much are they charging and so forth. But we also have challenges where we have medications where either the price is very volatile, and we talked about generics. Generics theoretically is an open market, right? As an economist, we can talk about barriers to entry, but then also medications. For example, we had a methotrexate shortage. Methotrexate is a pharmaceutical used to treat children with cancer, like ALL, or people with rheumatoid conditions. And so I guess one question is that how do our policies then potentially impact creating? So we try to address the issue around, on one end, increasing drug prices, increasing spending. What about on the shortage side? What is happening? And there, are we not paying enough for some drugs actually, so that we don't end up with shortages and people can't get the treatments they need? So can you address that? What kind of system do we have to have in place to be sure that we don't end up with shortages of certain medications people need?
Dr. Pan, I advocated for a pay raise for you. But thank you for that question.
I took a pay cut to do this.
Okay.
By the way.
So if we were doing textbook economics, we would think if you're going to get a lot of money for something, you would be less likely to see a shortage of it in the market from if you weren't going to get as much, because companies' priorities might be clarified through a reimbursement system. That would be my super short answer. I suspect that sometimes shortages happen even in drugs where there isn't a small amount of reimbursement. What do you think?
Well, I mean, I think that's what. So I think when we look at the whole picture, we want to be sure. I mean, ultimately, I think we all want access for people and affordable access. So certainly, we hear from patients they're concerned they can't afford medications. Their out-of-pocket expenses are too high. We hear from insurers that the total cost is too high. We also hear from patients when the drug isn't available, period, right? No one's manufacturing it anymore, right? Or there's insufficient supply. So whatever solution we land on, hopefully will address or multiple solutions, but hopefully will not cause shortage issues, as well as we might to address one part, but we have to be sure we don't cause another problem. And then I guess the other question you mentioned is that Millie, drug pricing is sort of a multi-layered process. So the manufacturer sets something with the PBM, right? The benefits manager, that may be a separate entity from the plan that then charge, then the patient has their share of costs, the specialty drug is usually percentage or some copay or so forth. So I guess the question is that, because you sort of said the manufacturer knows how much, but actually, well, the manufacturer certainly knows how much they sold it for, but they don't know how much, to what degree do they really know how much the patient paid for it?
Good.
Can you speak to that? Yeah.
I probably the manufacturer, I would have to have them come up here and actually answer the question for you,
Okay.
but it seems that if they're getting paid, it doesn't matter to them what's happening farther down the pipeline in terms of what kind of cost sharing is occurring, as long as the manufacturer is getting
Right.
what they had requested.
So yeah, so the manufacturer will get what they requested. Someone could up or down the price in between. So what the patient's paying may not necessarily reflect the manufacturer's charge, depending on how much each middleman wants to, depending on what they want to do with the price.
Right.
And they could give a discount and lower it. They could be balancing out. So because it goes through several middlemen before it actually gets to the patient.
Yes,
Correct?
that's correct.
That
And
is
I
correct.
think we were talking a little bit about the pharmacy benefit management companies that will negotiate on behalf of health plans or large
Right.
employers for discounted rates
Right.
on their prescription drug prices. And we've heard and seen in our research that through our research that, in fact, it looks like some of the pharmacy benefit managers are keeping a larger proportion of the rebate that may have been given to
Right.
the people that they're
Right.
representing. And so, yeah, all of that you kind of start squishing the balloon, and it keeps popping out in different places
Right.
along the line, so that different payers are going to have to pay different amounts.
So if we want to try to achieve greater transparency, we actually have to have transparency along the whole line. Correct. Okay. And then just the final question. In terms of, I used to do this research way back when, but looking at how much we spend on research, because certainly I hope that most of us agree we want to continue to see innovation, new treatments. As expensive as Spaldi is, I think it's great we actually have a cure for hepatitis C versus the previous treatment. Can you maybe speak to the percentage that's spent on R&D by, let's say, the federal government, U.S. government, NIH, versus how much is spent by the pharmaceutical industry on R&D?
No, I don't have that answer, but I could get it for you. But maybe Dr. Hodge has it.
Yeah, strangely enough, I don't have that answer either.
Okay.
However, there is a bit of contention around how much it does cost to bring a drug to market. There are some people who believe it's above the 1 billion mark, and there are some people who believe it's below. And I suspect the truth is probably related to which drug we're talking about. So the short answer is I don't have the answer to your question.
Well, the short answer is we spend about $30 billion in NIH. I think we're trying to bump it up to about $35 billion. However, admittedly, this is worldwide. The pharmaceutical industry spends about $135 billion. So we spend a fraction what the industry spends on R&D. So, okay, thank you.
Thank you very much. Dr. Hernandez?
Thank you, Mr. Chair. I want to just kind of follow up on some of the comments that Assemblymember Chu made with regard to our healthcare system, how it has evolved since the Affordable Care Act or its implementation with, medical loss ratio. We've got providers making less money, obviously, looking at what hospitals make. And there's obviously the industry that we're dealing with and talking about today doesn't have that checks and balances. And then again, to kind of follow up on what Assemblymember Waldron said with regard to the value. And yes, for example, you take expensive newly drugs that have come to market. You had mentioned and you talked about that value. And I think that's a conversation that we haven't had in the legislature. And I think transparency is important. Obviously, I'm a proponent of anybody making a profit, but not at the expense of taxpayers and gouging the taxpayers. I am not a proponent of price fixing or controlling prices. So I believe in transparency, but I think a conversation that's missing is the value portion of it. Because yes, so let's take a specialty drug. If it is truly value to the healthcare system, and saves in the long term, then we should invest and we should pay it. But I don't know if every drug has the same value. That's the concern that I have. And we seem to be missing that conversation. How do you see that in controlling drug prices, and how does that occur? How do we have that conversation with the drug companies? I mean, is this an integral part of controlling drug costs? Maybe talk to it. I'd like to kind of speak to it if you can.
So you have to understand I'm in the business of research, so I'm here to sell you research.
But I want an answer to solve the problems of controlling drug costs.
So it starts. Oh, well, that's easy. So it starts, in my opinion, with understanding what you're purchasing. If you were going to buy a car, if you were going to go to the store to get something, you would probably want to make sure you understood what you were paying and what you were getting. Many, many other countries throughout the world have a system where they examine or consider the value of what they're about to purchase. And here's the difficult part. If it doesn't seem like good value for money, they're willing to say no. And that can be a very difficult thing for people to do, to say, yes, we know it works, but the costs are so high that we feel it's not worth it. Generally, people start with the easy ones. We don't even know it works, and we're not going to pay a lot of money for it. But the advanced, the full contact health technology assessment is taking a look at things that might provide only marginal clinical gain and saying, look, the amount we're going to have to spend on this could be spent in a better way. It's not that this isn't worth it, it's just that something else we can get will have greater value. And I believe that discussion begins with actually having evidence about what it is you're buying. What's the clinical gain? What are the patient values? How will this affect the system? And oh yeah, how much more will this cost? So when I will know we are ready for that discussion when there's an uptick in demand for evidence about what we're purchasing.
He means when he gets more grants funded, I think is what he means.
Subtitles.
So it's ultimately coming down to making choices and making tough choices, but I think it still comes back to transparency.
Yes. Because how can you, as an economist,
Right.
I think it's hard to make good decisions if you don't have full information. Full information would come from your transparency.
And it's interesting, I think, I forgot which one of you made that comment with regard to what other states are starting to do and talk. Maybe it was you, but I think you're starting to see that conversation because the effect that drug prices are having on the economy and the economics of healthcare and the cost to the consumer. And we as policymakers, guess what? We're going to be held responsible and we're going to have to listen to our constituents. So anyway, thank you very much.
I just wanted to add one other thing that Dr. Hotch gave sort of a theoretical answer, but in more applied kind of experience, is that there are reports now that pharmaceutical manufacturers are starting to engage in contracting with payers that are outcomes based. So for a particular drug, I think Primera Health has a contract for specific drugs where they're guaranteeing a certain health outcome over a certain period of time. So those things are sort of starting to become a little bit more prevalent than they ever have before.
Senator Wolk?
I want to follow up on what Chair Hernandez was talking about. We have been struggling with the issue of disclosure. We have bills in front of us that are dealing with that in the area of transparency. You mentioned, I think I heard early on, that this issue of transparency with relation to pricing exists worldwide. It's not simply here in the United States. So have you or any of your colleagues done any analyses on what kinds of systems that sort of reduce or unravel that secrecy, that result in price reduction?
I believe that most of the research has been about appreciating how little there is to study about the exact accurate number. And that leads you to either advocate for transparency, and we've seen that in the literature, or try to design systems where, given you don't have transparency, how can you optimize? What's the second best solution for you? For example, in Canada, a few 5 to 10 years ago, even the provinces didn't know what the other provinces were paying for the very same drug. Then, although there was a transparency issue, because they were able then to negotiate together with a larger group of people, they're now, in theory, able to get better prices because they've come together. Still, no one knows the exact price. The transparency is not there. But in theory, they've been able to improve and still hold the lack of transparency there. It's not been changed.
And have outcomes been a part of that process?
When the
Because
drug...
clearly there's not rationing, but there's some benefit versus cost that enters into the Canadian system. So
Yes.
is that part of all that negotiation process?
Yes, it starts out at the federal level. There's a separate system for cancer drugs, and there's a separate system for all other drugs. When a submission is made, when a dossier is sent in by a company, it has 4 parts that it's considered. The first part is the clinical evidence. The second part is the economic evidence. That's just the what are we paying and what are we getting. The third part are patient values. Those are taken seriously. And the fourth part has to do with system feasibility. For example, maybe it's a drug that needs a genetic test. Well, then you better have the genetic testing in place. After that recommendation is made based on those, negotiation ensues and a decision is made. But no one knows the final price.
And that's at the federal level, not the provincial level.
The
province level.
recommendation is at the federal level. The decision is at the provincial level, which initially led to a lot of difficult situations where you could have 2 provinces right next to each other. One covers the drug and the other doesn't. But because now they're negotiating together, there is less likelihood of that happening.
Interesting. Thank you very much.
You're welcome.
Anyone else? I have one question, and first of all, the questions are great, and actually this panel has gone a lot longer than we expected, so this hearing may go longer than we expected. So appreciate that, and a thank you for bearing with us here. So you made a statement, and I'll try to paraphrase this or come back to that, or at least the theme anyway. Other countries, are they making those value decisions, and is that why they're able to keep their costs down? They're saying, you know what, the cost of this is too high, therefore we're not going to allow this, therefore not going to allow this kind of treatment. So that sort of rationing of care is something that we don't do in this country.
In fact, no. And what's amazing to me is to notice the language. Some people would call it rationing, some people would call it prioritization, some people would call it smart shopping. I've seen it repackaged as value for money or value-based insurance design. It's this notion that you're going to take a look at the value, and based on it, you may not purchase. It's possible that this might not be purchased. And it takes a great deal of courage to be able to say our resources could be better used in a different way. And if you have the power to walk away, you have the power to get better prices.
So do you, and this, we're going beyond drug pricing, but I'm curious now, because is this pervasive within our healthcare system that we have made these value decisions to pursue care? Is that why, as an economist, based on that, we're seeing such a discrepancy between the percent of GDP for U.S. versus some of the other countries? And that's a really difficult question, and you might deserve a raise after today too. But is this somewhat a cultural phenomenon? Okay, I see emphatic nodding there. So we have this is the way our system has evolved based on our values as in this country, and that other countries have made other different kinds of value decisions. Is that a fair characterization? Okay. You didn't have to say anything, but you did nod. Okay. So okay. Well, first of all, I want to thank you all very much thank you both very much for being here with us, and you might stick. It's up to you. You can stick around. There may be other questions, or you may just want to spend the afternoon with us. So, anyway, but thank you very, very much. So,
thank you.
Mr. Ben Johnson, representing the LAO, please come on up.
Good afternoon, Mr. Chairs, and to the rest of the committee. My name is Ben Johnson from the Legislative Analyst's Office. Beside me, I have Mark Newton, the Deputy of the Health and Human Services section. And I'm here to present an analysis of the California Drug Price Relief Act as our analysis actually stands today. The LAO's role is to provide an objective analysis for each voter initiative that qualifies for the ballot, which is published in a voter guide that is published prior to the election. We don't take a position on the initiatives we analyze, and in this case, we are continuing to complete our analysis of this initiative. We could revise some of our assessments should any new information come to light. Nevertheless, what we present to you represents many months of working on this initiative, working with the proponents and opponents and other stakeholders. You should have all received a handout in your packets, which contains a good deal of information. I'll loosely follow that, but I'm really going to present the main takeaways from that handout today. So in sum, what this measure would do is it would prohibit state entities from paying more for any prescription drug than the lowest price paid by the United States Department of Veterans Affairs. We believe at this time the fiscal impact on the state is unknown due to two primary factors. One, a lack of transparency around the prices that the VA pays, especially around the lowest price that they pay, and two, uncertainties around how manufacturers would respond under this initiative. On page 2, we start with some background. The state pays for or purchases drugs under many different programs. For example, by providing health coverage to the state's low-income residents through the Medi-Cal program. Annual expenditures in 2014-15 exceeded $4 billion, with the largest spender being the state's Medi-Cal program, even when you exclude the managed care side of the program. This measure divides state prescription drug spending into two distinct types, both of which would ultimately be subject to the measure's price ceiling requirements. The first is where a state entity may purchase directly from a drug manufacturer. And the second is where the state is an ultimate payer of a prescription drug, such as when the Department of Healthcare Services reimburses pharmacies for the drugs that are maintained by Medi-Cal beneficiaries. But to take a step back, the prescription drug market, as was described by the previous panel, has really two notable features. One, that different payers pay different prices, often for the same drug from the same manufacturer. Kaiser may pay a different price than Blue Shield, for example. And then there is a lack of transparency around what the different payers pay for their drugs. And this extends to state departments, even within California. One state department might not have access to the pricing information of another. In addition to paying for drugs in a variety of ways, the state pursues a number of strategies in order to reduce the state's prescription drug spending. For example, Medi-Cal obtains discounts from drug manufacturers in exchange for removing their drugs from prior authorization requirements, ultimately easing the burden, the administrative burden of prescribing the drugs. Turning to the federal government, they similarly employ a variety of strategies, which were also previously described, including the price ceilings that price manufacturers may charge federal purchasers, which are typically based on or discounted from favorable prices given to private or other non-federal purchasers. Moving to page 5. The VA, which provides health care to approximately 9 million veterans across the country, obtains additional discounts below these price ceilings from drug manufacturers that lowers their prices below what they're federally mandated to be eligible to receive. One strategy that the VA employs is to use a fairly narrow formulary or list of drugs that VA doctors may prescribe, which gives an incentive to manufacturers to compete over price to have their drugs be made available. On page 6, we turn to describing the proposal, which establishes a price ceiling by prohibiting the state from paying more for any drug than the lowest price paid by the U.S. VA. This is after all discounts and rebates are taken into account. And because the lowest VA prices do set the benchmark, it is limited to the drugs that the VA ultimately purchases. The price ceiling applies regardless of whether the state buys the drugs directly from manufacturers or serves as an ultimate payer. and the measure does exempt one state program or sub-program, Medi-Cal's managed care program, from the price ceiling requirement. Finally, the measure places responsibility on the Department of Healthcare Services to verify that each state entity and program is paying no more than the VA price, the lowest VA price, for each prescription drug that they pay for. On page 7, we begin describing the fiscal impact of this initiative as we see it today. We can say that the measure would introduce some new minor state operations costs, for example, by requiring the state to verify that each program is paying less than the VA price. The overall fiscal effects, however, are highly uncertain. The first source of uncertainty is whether or not the lowest VA prices are publicly available. While the VA publishes certain prices and price schedules that is eligible to purchase under, the VA so far, despite attempts by our office to contact them, they have declined to confirm whether or not the published prices accurately reflect the lowest prices that the VA pays. It is our understanding that the VA regularly negotiates prices below what the price ceilings are that all federal purchasers are entitled to, and that in many cases these negotiated prices are kept confidential. The confidentiality of VA prices could compromise the state's ability to implement this measure, as the state would not have a price by which to compare its own state prices. Now, it is possible, though it's uncertain, that the state may be afforded some discretion if it were to come before a court to implement this measure based on its best estimate of the lowest VA price. But ultimately, how the state would implement according to the best estimate and what its effects on the fiscal impact would be of this initiative, those remain uncertain. Moving to the second source of uncertainty, the fiscal effect of this measure remains uncertain even if the lowest VA prices can be identified or estimated. And the reason is that it is difficult to determine or predict how drug manufacturers might respond should voters approve this initiative. Here we'd like to highlight 3 plausible of many possible manufacturer responses, each of which would have something of a different impact. The first scenario is where drug manufacturers offer the lowest VA prices to the state. This is the scenario in which the state may achieve the most savings as a result of this measure. However, these savings would be contingent on manufacturers not raising the prices of drugs that are not purchased by the VA, but that the state pays for and therefore would not be subject to the price ceiling requirement. The second scenario is where drug manufacturers decline to offer the lowest VA prices to the state. While the measure restricts what the state may do, paying more than the VA price, it places no obligations on drug manufacturers to extend VA pricing to the state. And this could result in 2 divergent state responses. The first is that some state programs might modify their formularies and offer either only those drugs that drug manufacturers would offer at the VA price, or they could offer, they can offer those drugs that the VA does not purchase and for which no price ceiling applies. This response, however, is not an option for at least one state program, the state's Medi-Cal program, which is required under federal Medicaid law to offer almost all FDA-approved drugs to its beneficiaries. Now, the measure does have language that protects the state from having to contravene this federal Medicaid law, because the measure stipulates that the price ceiling only applies insofar as impermissible under federal law. Nevertheless, the measure could endanger some supplemental rebates or discounts that DHCS, or Department of Healthcare Services, receives from drug manufacturers, because these rebate agreements may conflict with the measure's requirements. Ultimately, under this scenario where drug manufacturers decline to offer VA prices to the state, it's difficult to determine whether or not drug spending would increase, stay roughly the same, or could rise as a result of the initiative. The final scenario that we lay out is if drug manufacturers raise VA drug prices. This would allow manufacturers to continue to sell their drugs to the state while minimizing any reductions in their revenues. When in the 1990s, Congress established a link between VA pricing and the pricing that all Medicaid programs across the country are eligible to receive, VA drug prices rose before Congress subsequently reversed their decision and removed the linkage between Medicaid and VA pricing, providing evidence that benchmarking prices to the market's best price can, at least in some instances, result in that best price ultimately increasing. So here again, the fiscal effects are uncertain, as they would vary depending on how much manufacturers raise VA prices and tie state prices to those higher VA prices. So to conclude, whether or not this initiative would result in drug-related savings is unknown at this time due to the uncertainties around whether or not the lowest VA drug prices are publicly available and how manufacturers would respond in this initiative. Thank you, and I'm available to take any questions that the committee may have.